Hi everyone. Today I'll be talking about fracture management of maxillary and mandibular fractures. So I'll be sharing my screen. Myself, Dr. Saurabh Kumar Raut. I have graduated from Rajiv Gandhi University. I'm a fellow of AOCMF. I did my fellowship under Dr. Niels Kirich from Hanover Medical School, and I'm a consultant craniomaxillofacial surgeon practicing in Orissa. So coming to the first slide, midface skeleton is made up of zygomatic bone, palatine bone, zygomatic process of temporal bone, lacrimal bone, vomer bone, ethmoid, and pterygoid plates. The characteristics of midface skeleton. Midface formed of a large number of bones which articulate with one another and rarely fracture individually. It forms a cushion from the trauma directly towards the cranium. The buttress of the midface, the vertical buttress, and the horizontal buttress. Which are the vertical buttresses? Vertical buttresses are nasomaxillary buttress, zygomaticomaxillary buttress, and pterygomaxillary buttress, where the horizontal buttress are superficial orbital rim, zygomatic arch, and inferior orbital rims. Now coming to etiology of maxillary fractures. It can be from road traffic accident, which is the most common, sports injuries, interpersonal violence, fall, workplace injuries, industrial accidents, and war casualties. Now coming to the classification of maxillary fractures. René Lefort in 1901 classified the maxillary fractures into three categories. He stated as Lefort 1, Lefort 2, Lefort 3. As you can see from the picture. Now coming to Lefort 1. Lefort 1 is a low-level fracture, is also known as Guerin fracture of subzygomatic fracture of floating maxilla. It travels from piriform aperture from one side and crosses the canine fossa, then the zygomatic arch and lateral wall of maxilla sinus, and finally meeting at the pterygomaxillary fissure. You can see from this picture. So when it occurs bilaterally, whole maxilla becomes free from the midface and becomes floating maxilla. What are the clinical features? Clinical features resulting from this are blow in front of the mouth, open the apices of the teeth, extraoral swelling of the upper lip and laceration of the lip, increase in vertical dimension of the face because of the floating maxilla. There can be epistasis, the bleeding from the nose. That can be pain. And the clinical feature intraorally are ecchymosis in the buccal sulcus, as you can see, buccal sulcus, Guerin sign. What is Guerin sign? We have to know that. And laceration of the labial mucosa, it can have anterior open bite, posterior gagging of occlusion, tenderness that can be around the nasal aperture and the zygomatic buttress, and mobility of maxilla elicited at the level of anterior nasal spine. Now, another clinical feature we can have associated with that is mid-palatal split can also be found. And as we know, floating maxilla when happens on both sides, and we can have a crackpot sound. Now coming to the Lefort 2 fractures. Lefort 2 is also known as pyramidal or subzygomatic fracture. It travels from the nasal bone, frontal bone, lacrimal bone, floor of the orbit, infraorbital rim, and it crosses the lateral wall of the maxillary sinus, the zygomatic buttress, pterygoid, as you can see, pterygoid fissure, and ends at the middle third of the pterygoid plates. You can see from this picture, this is how the maxillary Lefort 2 fracture travels, and finally it meets at the pterygoid plates here bilaterally. What are the clinical features? Clinical features of Lefort 2 usually results from strong force applied in the center region at the level of the nasal bone. Extraoral features can have moon face appearance, increased vertical dimension, disface deformity, bilateral circumorbital ecchymosis, chemosis, you can see, and subcongenital hemorrhage. In this picture, you can see. Clinical features are increased intercanthal distance in between the two pupils, depressed nasal bridge, epistasis, CSF rhinorrhea can happen if this involves the cribriform plate. The CSF rhinorrhea is through the nose, and We have the tenderness and step deformity in the infraorbital region, bilaterally or unilaterally. Infraorbital nerve paresthesia if it involves the infraorbital nerve. Intraoral clinical features are gagging of occlusion with anterior open bite, ecchymosis and vertical of buccal vestibule, crack pore sound on percussion, mobility of maxilla at the level of the nasal bridge. You can see in this picture, you can feel the movement of the nasal bridge here when you try to maneuver the maxilla holding the upper front teeth, and that can be associated with mid-palatal split. Now coming to L4-3, the subzygomatic fracture or craniofacial disjunction. It travels from frontal nasal sutures. It involves the ethmoid bone, cribriform plate, orbital foramen, enters the inferior orbital fissure. Okay, in this picture, and divides into and bifurcate first the lateral wall of the orbit, which form the frontal zygomatic suture, and second is pterygomaxillary fissure, fractures of pterygoid plates here and here. You can see. Clinical features of L4-3 are moon face, panaphus deformity, subconjunctival hemorrhage, diplopia, restricted eye movement. It involves the muscles of the orbit and ophthalmos, increased intercanthal distance. And then these two canthus, depressed nasal bridge, epistasis. Other clinical feature associated with the anosmia, because it can involve the nasociliary nerve, elongation of the face, tenderness and step deformity at abscess suture, alternate pupillary levels. Intraoral are anterior open bite, molar gagging, mid-palatal split, and mobility of the maxilla at the frontozygomatic and the nasal bone level. Now coming to modified L4 classification. Marciani 1993 classified in a way that is divided into L4 1A, L4 2A, 2B, then L4 3A, 3B, L4 4 when it involves the L4 2 or 3 and the cranial base fractures. L4 4A supraorbital rim fracture, L4 4B is anterior cranial fossa and supraorbital rim fracture, L4 4C is anterior cranial fossa and orbital wall fractures. You have to go through this and you have to mention that in your classification column. Now coming to the palatal fractures. Palatal fractures, you can see from the picture, there are Henderson classification of palatal fractures, type 1B, 1A, 1B, type 2, type 3, type 4, type 5, and type 6. 1, type 1A, type 1B, type 2, type 3, type 4, type 5, and type 6. You can see from the picture. Now coming to radiographic examination. Radiographic examination of the L4 maxillary fractures can be done by CT scan, 3D face, which is the gold standard, or it can be occipitomental view 10 degrees to 30 degrees, and the paranasal sinus view 37 degrees. We can visualize the fractures of the maxillary. Now these are the lines we can see from the radiograph. 1, 2, 3, 4, and 5. Fifth one is known as trapnel. Other four are known as McGregor line. We can see is a Dolan line when you have a peer view. What are the basic principles of treatment of maxillary fractures? Basic principles are direct exposure and manual reduction of the fractures, reconstitution of the bony buttress of the midface to prevent elongation of the face and anterior posterior collapse of the maxilla, reinforcement of the paranasal and zygomatic buttress with mini plates, replacement of the missing grossly comminuted bone at the buttress with the autogenous bone grafts. What are the principle of fracture management? Principle of fracture management are divided into closed and open. Closed are you have closed reduction methods, and open we have fixation by non-rigid wire fixation, semi-rigid mini plates, or rigid direct compression plates, immobilization and rehabilitation. Now closed reduction can be done by various methods, by the suspension wiring method or by intraoral arch bar method, putting the elastics or putting the wires together in order to support the mobility of the maxilla. While manipulation and reduction of the impacted maxilla, we have to use the Rowan-Williams dissection forceps as well as the Hayton-Williams forceps. If there is a mid-palatal split, together we have to use both. Now coming to management, L4-1, we open reduction, mucosal incision placed 5 mm over the gingiva, mucoperiostal flap raised till the infraorbital foramen, infraorbital nerve is preserved, fracture reduced with Rose-Williams dissection forceps, occlusion is stable, Destabilize and MMF is done. Mini plate fixation on the vertical buttress. And you can see from here, mini plate fixation 1, 2, 3, 4. One is zygomatic bilaterally and one of the piriform bilaterally. And closure, final procedure observable. Leaford through fractures, similarly, we have to fix in the nasal region, nasal bone and infraorbital bone. You can see from this. And finally, the zygomatic bilateral zygomatic buttress. Of course, we have to do this disimpaction of the impacted maxilla with the rose disimpaction forceps. Now going to Leaford 3 fixation at the both zygomatic process, the fixation of the nasal bone bridge and zygomatic arch is done. Now, this can be, MMF can also be done by using the IMF screws. And here you can see from the picture, you can see there's a use of mini plates and screws in order to finally give a fixation, rigid fixation. Now, recent advances of this are a preoperative stereotherapeutic model. The plate contouring and precise positioning of the maxilla can be done. Automated mirroring software is now available in order to know exactly how much displacement is there and to use that use the software in order to reduce it in order to previous form. Intraoral surgical navigation methods are available. Navigation methods using the navigation probes, and endoscopic mid-phase fracture management can also be done in the recent advances. Now coming to mandibular fractures. Mandibular fractures are very common, and mandible being the only bone in the body which is mobile in mandible fracture is the only bone in the face which is only mobile. Being the most dynamic bone in the body, the muscles of mastication and suprahyoid group of muscle can lead to instability and fracture displacement, as you can see from this picture. Muscle attachment, there are various muscles attached to the mandible at different sites, which determine the displacement of the maxilla if the fracture occurs, as well as the movement of that. The weakest area of the mandible are junction of mandibular bone, alveolar basal bone, symphysis, parasymphysis, angle, condyle, and the teeth. Classification according to Dorland can be simple, compound, complex, comminuted, green stick fracture, pathological, impacted, direct, indirect, and atrophic. These are the various classification given by Dorland. Classification according to the anatomic side, dental-alveolar segment, there's symphysis fracture, there's a parasymphysis fracture, there's a body fracture, there's an angle fracture, there is a ramus fracture, there's a coronoid, and the condylar process fracture. The various percentage of fractures are also listed here. Condyle being the most common, the highest. Factor affecting displacement of the mandible. A muscle pull of the fracture segment, force of impact, site and direction of the fracture line, favorable or unfavorable fracture. Classification of unfavorable fracture, that can be favorable, unfavorable. Favorable can be vertically favorable, horizontal favorable. Unfavorable can be vertically unfavorable and horizontal unfavorable. Vertical favorable are fracture line runs from the outer buccal plate obliquely backwards and lingually and medially towards the restriction. You can see there is not much of movement. The vertically unfavorable fractures are fracture line runs from the inner lingual plate obliquely backwards and buccally, and medial movement is unrestricted. This is the picture of horizontal favorable fracture and horizontal unfavorable fracture. Is running anteriorly, it is running posteriorly, horizontal unfavorable fracture. While vertically, as I have mentioned here in this. What are the clinical features? Clinical features, indirect clinical features are swelling, ecchymosis, erythema, abrasion, laceration. That can be contusion or laceration of chin. They can be deformity because of bony contour to mandible and palpable steps deformity. Inability to close the mouth, trismus, tenderness is a pathognomonic sign of the fracture. Infraorbital nerve paresthesia can also be seen. What are the clinical features? Intraoral examination. Intraoral examination will find buccal and lingual sulcus ecchymosis, Coleman sign, step deformity occlusion, obvious laceration of the mucosa gingival tear. We can have paresthesia. What are the imaging studies we can do? We can do panoramic X-ray, panoramic view, lateral oblique view, posterior anterior view, occlusal view, and gold standard is the CT view as the computer tomogram. Emergency management used by fractures is reduction by using Bird's wiring method by 24-20 gauge wire, supportive bandage like barrel bandage method and four-tail bandage method. Management is by close reduction, open reduction, and finally by fixation method when rigid non-rigid fixation, wear osteogenesis, semi-rigid fixation by monocortical plates on lag screws, and rigid by direct compression plates. What are the various methods of closed reduction? And what are the indication, contraindication? Indication being non-displaced fracture, comminuted fracture, atropic mandible fracture in children, undisplaced condylar fracture. These are the closed reduction indication. What are the contraindication? History of seizures, compromised pulmonary function, psychiatric conditions are the contraindication. Advantages of closed reduction: daycare procedure, cost effective, avoid damage to the vital structure. Disadvantage being a restriction of mouth opening, only liquid diet intake, difficult to maintain oral hygiene, trismus can happen for a few weeks. What method of immobilization? By arch bar, eyelid wiring can be done. Closed reduction methods, IV eyelid wiring method, indirect wiring method. Different types of arch bar you can see. There is Winter, Jelenkos, Daughtry arch bar, Burns titanium arch bar, Bomax and custom made arch bar is nowadays available now. IMF screw, the recent advantages of this are we don't have to put wires in each and everything, so the oral hygiene becomes a little easier to maintain. It can be placed, screw can be placed quickly. It can reduce chances of needle stick injury from the wires. It can be used in heavily restored teeth. These are the advantages of it. Another method of closed reduction is external fixator. Management comminuted, it used in management of comminuted mandibular fracture. The screws placed in two on either side of the fracture through a stab incision and holes and drilled into the mandible, as you can see from this picture. Gunning split can be used in fracture of inguinal jaw fracture. Acrylic splint takes the form of modified dentures with bite block in place of molars, and space is provided in the anterior region in order to facilitate the food intake. What is the immobilization period? Young children, we have to immobilize. For young healthy adults, we have to immobilize for 4 weeks, children for 3 weeks, old age for 4 weeks in undisplaced, and for 8 weeks if it is displaced. The normal occlusion is induced using elastics on soft diet is maintained for 2 weeks more. Open reduction indication being unfavorable displaced fracture, panfacial fracture, manometer fracture if occlusion is not achieved by closed reduction. Contraindication are medically unfit patients are not indicated for open reduction method. Approaches, various approaches of open reduction are intraoral method, vestibular incision method, extraoral such as submandibular residence, retromandibular Heinz approach, exiting laceration method, transbuccal preauricular approach. Various methods of fixation, it can be wear osteogenesis. As you can see from the picture, transversus wearing can be done. We can use the compression plates, or nowadays mini plate fixation can be done in the fracture of mandible. Lag screws is generally done in the anterior region of the mandible. Nowadays, we have recent advances such as using of 3D plates, which can be, you can see from the picture, we can reduce the fracture in a three-dimensional way. Now, coming to Sanfy's line of osteogenesis, Sanfy's line of osteogenesis, as you know, these are the lines where maximum amount of stress is there, and we can get adequate reduction if you plate in this reduction. Anteriorly, the Sanfy's line divides into two, one above 5 mm, one in the inferior border, and 1 5 mm below the apices of the teeth. Body region, only one plate is sufficient. Where there is where the angle region, we have to plate in external oblique ridge region. As you can see from the picture, transbuccal approach of fixation of mandibular angle fracture we have done, and we have used the C-arm in order to know the exact position and the IMF and the position of the screws. You can see from the picture we have used the IMF screws in this in order to reduce the maxillomandible relation and to achieve occlusion. What are the advantages of a transbuccal approach? Less operative time, minimal scar is there, lower injury risk to the facial nerve. Recent advances of mandible fractures are computer assisted surgery. We can use the software in that, or custom made titanium plates or patient specific implants we can use in order to reduce the fractures. Now coming to question 1, as you can see from this picture, what is the diagnosis and what is the treatment plan for this? Second question, as you can see from the picture, what is the diagnosis of this and how will you manage this patient, whether it is done by closed reduction or open reduction, and you have to justify this region. Expected questions which are going to come in exams. Our theory question, which I'm talking about, classify maxillary fracture, discuss the management principle, and add a note on clinical feature, investigation, management of LIFO tree. Second question is classify mandibular fracture, discuss clinical feature, investigation, and management of mandibular fracture, as well as some of the questions like viva question like the Trapnell's sign, and this we can go for this Dorlan lines and all. These are questions which can be expected in exams. These are my references, Fonseca and oral maxillofacial surgery for clinician first edition. These are my basic books which you can go through, and all the best for your exams. Thank you.